Miss Naik, if you are on the call, if you'd like to share about the work well, please. If not, I'll continue. Currently I'm the chair at South Brooklyn Health, and I do have 25 years of experience in women's health and surgical innovation. I served as a vice president of medical board and president of faculty senate at my previous employment, and I'm honored to lead the high quality care for one of the most diverse patient populations in the U.S., and honored to be included in top OBGYNs with Consumer Research Council of America. Why is PMS and PMDD is important? Understanding is crucial because they affect daily functioning, relationships, and mental health of millions of women. The PMS, PMDD, they are usually collaboratively managed by OBGYNs, mental health specialists, the primary care physicians. But as an OBGYN, my presentation today will be skewed towards women's health. I want to apologize in advance if I use any medical jargon that I will try to explain throughout the presentation. But I'm very confident that today together we'll be able to define some symptoms of PMS and PMDD, physical, emotional changes during menstrual cycle, understand what is happening with the hormones and psychosocial causes that impact the well-being, and also be more knowledgeable and empowered by becoming familiar with self-care, medical, and surgical treatment guidelines. So definitions and overview. So far you heard two terms, premenstrual syndrome and premenstrual dysphoric disorder. So I want you to think about them as a spectrum of disorders. So if we talk about PMS, PMS is something, yes, bothersome, but something mild and manageable, often with self-care and over-the-counter medications. And PMDD is already more severe. It's on the spectrum of mental disorders and certainly needs an input from healthcare providers. The key term here is that cyclical. We are part of the nature. So if we think, let's say, about the moon, that the moon and lunar cycle that takes about 28, 29 days, there's probably some connection, and it is disputed in current research, with the menstrual cycle that's on average also is about 28 to 29 days. And there are both physical and mood-related symptoms. So if we look at the table, emotional symptoms such as anxiety, irritability, weakness, depression, and in severe cases, suicidal thoughts. And physical symptoms such as sleep disturbances, bloating, heart palpitations, joint pain, headache, brain fog, food cravings, breast tenderness, skin changes, and probably more that are not mentioned in these tables. So the key is cyclical. Cyclical means that these symptoms appear before menstrual period, before the menstruation, and then once the menstruation starts, they go away and we go back to our baseline level. So when I talk about menstrual cycle, you'll see the follicular and luteal phase. So it's divided into first half and the second half is called the luteal half. And the important part that these symptoms disappear once the menstruation starts. They do interfere with daily functioning, and as I mentioned, in severe cases can be associated with self-harm to the point of suicidality. So if we talk about the more severe PMDD, that usually it affects the small number of women, and we'll go through the statistics in a few minutes. But if you take cumulatively, that disability might last up to 4 cumulative years, right? So it's about 3,000 symptomatic days in the lifespan, in reproductive lifespan of the woman. Certainly associated with lower quality of life, and it affects not only the woman itself, but also the relationships with the spouse, with friends, with coworkers, and the community. There are more visits to healthcare practitioners, and unfortunately, many go untreated. So when I mentioned the symptoms in the table, right, the mental and physical symptoms, you can imagine that more than 90% and probably almost all women have at least one symptom, if not few of them. So 90% of reproductive age women will experience at least some symptoms, but only for 20 to 30%, the symptoms will be bothersome enough to meet the criteria for this syndrome. And only 2 to 5% of women will report severe and disabling symptoms with the diagnostic criteria for PMDD. It's very hard to diagnose this condition in adolescents because 60% of adolescents will meet the criteria for PMS, and with 50% reporting severe symptoms. But it's hard to say, is it because of emotional liability, which is connected to hormonal changes in puberty and adolescent development, or this is really the PMS and PMDD condition. A little bit of the historic glimpse. So Hippocrates described PMS long time ago and called it the latitude of the head. But it was only in 1931 when Robert Frank called it premenstrual tension. And the premenstrual syndrome, the term appeared only in 1950s. So if we go to 1980s and 90s, there is more thought that this is actually the disorder, and it's on the spectrum of mental disorders. But it's interesting that in 80s and 90s, it is thought to be more prevalent in Western societies and thought to be more socially determined entity rather than associated with any hormonal changes or any physiological changes. And thought to be mostly affecting that what we call the career women who are challenged to balance the high pressure jobs with the gender specific roles. But today, in 2025, the research says something very, very different. So if initially it was thought to be the disease of the more affluent and higher society, today it is known that it actually affects low to middle socioeconomic regions more. And today we know that the PMS and PMDD is the diagnosis across all socioeconomic and ethnic backgrounds. So when we talk about including it as a diagnosis, as a mental disorder, we are looking now into 2013 and 2019 when it appears in the classification of mental health disorders. In 2019, the WHO added PMDD to International Statistical Classification, and although it's classified as genitourinary disorder, it's also listed among the depressive disorders, right? So PMDD is classified as type of depressive disorder in American Psychiatric Association and is characterized by the cyclic recurrence of severe, sometimes disabling changes that affect mood, irritability, dysphoria, anxiety, occur in luteal phase. I'll go through the luteal phase in a minute of the menstrual cycle, and they subside around or shortly after the onset of the menses. So to understand the cause of PMS and PMDD, it is important to understand the concept of the hormones. What are the hormones? Horme is a Greek goddess of impulse, eagerness, setting oneself in motion, and energetic activity. So it is true. Why? The hormones are the messengers in our bloodstream. And these are the messengers that travel to many body parts, including the brain. So once they enter the cells, they trigger the DNA to start specific behavioral and specific body processes. They initiate the body processes, including the...
So sorry, Miss Dr. Maggie. The
Yes.
chat has been disabled so people can drop questions in the chat. Interrupt like how you're doing. I'm so sorry.
Okay. No. So should I continue?
Yes, I'm sorry. I just wanted to say that because they put that we could add questions in the chat, and
Okay.
we can't because the chat has not been disabled. Apologies.
Okay. Do I need to do anything on my end?
I think work well does. No, not you.
No. Okay, thank you very much. I'll
Sure.
continue. Thank you. So hopefully we'll be able to answer the questions. And if anybody has any questions after the presentation, I'll share my email, and please feel free to reach out directly. So going back to hormones, right? Hormone. It's Greek setting in motion. So signaling molecules, and they are not unique to humans. Actually, even plants have hormones. And one of the hormones that's called the axin in plant, it determines how the plant is going to grow and how is it going to respond to stress. So very similar to humans. So menstrual cycle is very beautifully orchestrated by the hormones, by these messengers that come, that are released under the influence of the brain and the ovaries, and then they affect the uterine lining that is going to grow under the influence of hormones and then shed at the end of the menstrual cycle if pregnancy did not occur. So everything in our body is all the hormones. They are there to prepare the uterus to be ready for the pregnancy. But if pregnancy does not happen, those hormones they drop, they decrease, and the menstruation starts. So if we look at the graph, the menstruation is divided into two halves: follicular phase, luteal phase. If we take 28-day menstrual cycle, follicular phase will be about 14 days, and luteal phase will be also about 14 days. It changes throughout from woman to woman and throughout the lifespan. The luteal phase, the second half, is relatively stable, about 10 to 14 days, but the follicular initial phase can change in the number of the days. So what happens? The ovaries, right? The eggs are in the ovaries. So those eggs or the follicles, they grow. And once they grow under the influence of hormone estrogen, then they release the egg. That's called the ovulation. And after ovulation, the follicle becomes what it's called the corpus luteum. And corpus luteum starts to produce the second hormone that's called the progesterone. So these two hormones, estrogen and progesterone, are very important, not only to regulate the menstrual cycle, but as I mentioned, to regulate many body functions and influence the mood and brain health, bone health, cardiovascular health, even skin, and many, many other functions. Very important. Just a few facts about the menstruation. The average age is about 12. And if we go back, let's say, to 1800s, the average age was 16. So when we're talking about the Western culture or industrialized or modern culture, maybe there is some truth to it because the onset of the menstruation changed and it is earlier. So it usually is 3 to 5 days, but can average between 2 to 7 days, and it's considered normal. And normal menstrual length is from 22 to 35 days. Average age of menopause is 51, right? So if you think about menstruation that was happening later before, or if we look even in prehistoric women, the menstruation was very rare. There was a lot of time spent on the pregnancy, on the breastfeeding. So because of during pregnancy and breastfeeding, the hormones are stable, they're in a steady level, there are not that much fluctuations. Maybe we can speculate, we don't know, but we can speculate that PMS was more rare then than it is now. But we don't know, right? We don't know. We can only see what the current research shows. So the average blood loss is about 35 cc's from 10 to 80 cc's. It's considered normal. So in many women older than 40, the length, the follicular cycle, the first half of the menstrual cycle shortens, but the second half relatively remains stable. So if you look at these hormones, estrogen, right? We mentioned estrogen that's produced by the follicles, the progesterone that's produced in the second half of the cycle. When we talk about FSH and LH, these are the letdown hormones that come from the brain that allow this estrogen and progesterone to be produced. We're not going to talk even about testosterone, which is also very important for our health, for sexual function and libido. But what is important to mention that it's not the actual level of the hormone that's important for the PMS and PMDD, but fluctuations in the hormones and even more important, the individual sensitivity to those fluctuations. So when we think about fluctuations of hormones, what are the times in our years that are we see those fluctuations, right? It takes several rehearsals in pre-menstruating, right, adolescence until the menstrual cycle is established. So fluctuations are more severe before the menstruation starts. That's why we see PMS more in adolescence. The second time when it's vulnerable, the pregnancy is also steady state. You have high levels of estrogen and progesterone, and they're steady. But once the delivery happens, right, postpartum period, that's when the drop of the hormone happens. So you will all very well aware of the postpartum depression. And the third time is the perimenopause. So when you saw previous slide how beautifully orchestrating and synchronized those hormones are during perimenopause, those synchronicity goes away. So there is erratic level of hormones, erratic fluctuations that affects perimenopausal women and their symptoms. So one thing we can say that if women complain of PMS and they're diagnosed with PMS and PMDD, they're not only vulnerable at that time period, but they need to be aware that it has to be a more attention at the time of postpartum period and at the time of perimenopausal. These are the women that are more likely to be symptomatic during those times also. So is it really the estrogen or progesterone that certainly has effect of many functions of the body, but other systems and other hormones that they trigger that have more effect on the mood, for example. And we all know about serotonin, right? Serotonin is a happy hormone. And what happens, that decline of the estrogen in late luteal phase, it's going to affect the serotonin and decrease the serotonin levels. Also progesterone and its metabolites, also known as allopregnenolone, right? These are the progesterone metabolites. Progesterone itself has the calming effect. So if you think, why are we a little bit more sleepy before the periods? Because progesterone has a calming effect. But that calming effect is also through another hormone that's called the GABA or GABA receptors in our brain that have that calming effect. So it is surprising that progesterone, right, affects the GABA receptors, and the GABA gives the calming effect. But when the progesterone drops, something happens with those reactivity or sensitivity of those GABA receptors. Or even when progesterone is high, sometimes those receptors are malfunctioning. They're not as sensitive in certain women or from one cycle to another. So instead of calming effect, we actually see more irritation, more agitation, and more mood changes rather than what we should be seeing. There is a genetic predisposition in some women, for example, sisters or mothers are affected, and we see a similar effect in the women in the same family. Stress exposure is also very, very important. So even previous stress, even childhood stress, sometimes it echoes in our reproductive years into more sensitivity to the hormones. And the new theories are developing, and some of them say that there are negative bias in cyclical processing of nonverbal affective information, such as, for example, the face recognition and sensitivity to certain behaviors. That some women are more sensitive to those nonverbal stimuli. And it has to do again with physiological mechanisms in certain women. When I spoke about the menstruation, right, the prehistoric women, how menstruation was probably less than it is today, then maybe that explains the menstrual exposure theory of the modern living. Also, earlier puberty, nulliparity, which means not having children, so more frequent menstruations, later childbearing age, decreased breastfeeding, all of that might affect the symptoms as well. And it can worsen with age and closer to the menopause. Right. So this is a busy slide, but as I mentioned, there are so many physical and so many mental symptoms. But again, if we want to distinguish the PMS from PMDD, then we need to put the focus on the severity, of the syndrome that is more telling us that this is a PMDD and not a PMS. So how do we diagnose, right? We spoke about the hormones are important, and hormones change throughout the lifespan. They're different from one woman to another, and different in the same woman from one cycle to another. So once, let's say, OBGYN, as an OBGYN, when I see the patient, how do I make the diagnosis, right? I rely often on the recall. And recall can have a bias. We might think that the previous cycle we experienced certain symptoms, but sometimes we can exaggerate or actually underreport. So even though we do rely on the retrospective recall, what is important is to ask women to come prepared. Come prepared means that to start having the diary. So prospective documentation. So you come with the document to your physician. Just imagine you have only 15 or 20 minutes, right, for your visit. And to be able to recall all the symptoms and everything you're going through, it's very hard through those 15, 20 minutes. So as a practitioner, probably something that we will ask the patient is to come prepared with your diary. So it's easier for us to review. So it's easier for us to tailor the treatment towards your particular symptoms. And again, PMS, PMDD is managed by several providers. So let's say if you go to PCP and you feel that you didn't have enough time or enough opportunity to convey everything you're going through, then please make appointment with OBGYN, make appointment with the psychiatrist. So hopefully together as a team, we will be able, maybe not with one appointment, but with several appointments to see what's going on and give you the practical and medical advice. So again, 2 months of prospective symptoms are usually enough. There are certain several paper diaries that are available on the internet. There are also specific apps that you can use and that track your symptoms. Sometimes the diary is inconclusive. Why? Because today I'm talking in a presentation about the classical menstrual cycle, right? When it's every 28 days. But imagine women who, for example, have diagnosis of polycystic ovaries, so they have irregular periods. Or sometimes women are on birth control pills, right? So the birth control pills, certain components and hormonal components of birth control pills, they also have estrogen and progesterone. And different pills with different formulations and dosages, they can also affect the symptoms. They sometimes can even cause the symptoms, right? They're supposed to help, but certain formulation can exacerbate or cause the symptoms. Also, we have a subset of women with pre-existing psychiatric disorders, pre-existing, let's say, bipolar, even ADHD, anxiety, depression. So what happens that those symptoms are worse before the period. But once the period is over, you don't go to symptom-free, you go to your pre-existing conditions. And it's harder to diagnose the PMS and PMDD in those women. Sometimes there is a hysterectomy, right? The uterus is not there, but ovaries are there. So women are still in their reproductive years. They're still making those hormones. So you cannot clearly link the symptoms to the menstruation because there is no uterus and no menstruation. But the diary sometimes helps to still document and show the cyclicity of those symptoms when ovaries are still functioning. And sometimes we can go to drastic measures such as suppressing the ovaries, right? Suppressing ovaries to see if we take ovarian hormones out of equation, do symptoms disappear, and make diagnosis that way. Again, there is a lot of differential diagnosis. So let's say if there is a thyroid disease or patients are on thyroid medications or certain medications that are helping with the mental health conditions, right? So those medications themselves also can cause irritability and certain physical and mental symptoms. Anemia, diabetes, polycystic ovaries. I mentioned the birth control pills. Sometimes autoimmune disease. Why autoimmune? One of the theories of PMS, PMDD is an increased inflammation in the body, also increased stress. So certain diseases can cause that inflammation and exacerbate the symptoms. So again, when we look at the diagnosis, we need to be a little bit strict, because you see those symptoms are all over the place. It's hard to diagnose a certain women. So that's why when we come to the diagnosis that is in the classification of mental health disorders or genital urinary disorders, we need to be a little bit strict and say, okay, so you have to have certain number and certain type of the symptoms to make that diagnosis. So today this is the classification, which is one of the following must be present, right? One of the following core symptoms must be present, such as marked affective lability, irritability, depressed mood, anxiety, tension, feeling of being keyed up or on the edge. So one of those symptoms. But total of five. So what makes it five? So one of this core, one or more of the core, and also so four more, right? Or four more or more of these additional symptoms, such as decreased interest in usual activities, subjective difficulty in concentration, lethargy, fatigue, marked lack of energy, change in appetite, overeating, special cravings, right? These cravings are very interesting too, because so what happens during menstrual cycle when the second half, the progesterone is produced? Progesterone increases the metabolism, right? So when the metabolism is increased, the body goes into so-called catabolic state. So that's why there is a craving. The body tells you that I'm spending a lot of energy, more than at the beginning of the menstruation. So I need additional energy. So please don't feel bad about the craving. So extra banana or extra chocolate is absolutely physiologically normal in the second half of the cycle. Hypersomnia or insomnia, right? Sense of being overwhelmed, out of control, and physical symptoms such as breast tenderness, for example. Progesterone does affect the breast tenderness, the bloating, joint and muscle pain, and weight gain, also very important. So that weight gain, if it's not continuous weight gain because of the nutrition and lifestyle and so forth, that weight gain is usually limited. Again, it's cyclical also, and most of the time associated with retention of the fluid. So it's just couple pounds, and they usually also go away after the menstruation is started. So what do we do? So you see a lot of symptoms, right? So what do we do about it? Can we help ourselves? Certainly, anytime that they are bothersome, anytime that they cannot be controlled, please seek the attention of the healthcare provider. But there are certain self-care strategies that are very, very helpful and advised. So first is awareness, right? This is the also reason why we're having this conversation today, is to increase the knowledge and awareness that I'll give you example. Just a few days ago, I don't know if it was connected somehow to this talk that I was planning, but a few days ago I saw one of the coworkers, and she was having a tense conversation with another coworker. And the conversation was the work related, and she was very reasonable, very logical, and I would say very right in what she was saying. But then the end of conversation, she said, I'm sorry, I'm PMSing, right? So I felt that women sometimes they feel that they have to provide the excuse of something that physiologically is very well explained, and it's in nature. So I'm just hoping that with the knowledge, we don't have to excuse ourselves for those symptoms, right? Because they are normal, and sometimes they're not normal. But again, this is the diagnosis, this is the disorder, and not something that we should feel guilty about. So awareness is very, very important. Validation of those symptoms and educating women is also very important. And tracking, right? When we said this is cyclical. So when you track and this is something that comes and goes, it makes it more manageable also. Also, coping strategies such as stress reduction, sleep hygiene, very important. Going to sleep on this, try to go to sleep at the same time and wake up at the same time. And massage therapy, relaxation, yoga. These are all accessible, and they certainly help to cope with the symptoms. Minimizing triggers. So one of the triggers, for example, are the increased levels of sugar. So carbohydrates, especially simple carbohydrates. What do carbohydrates do? The sugar. It increases our insulin level. And insulin level also has an effect on many organs, including the brain, and it increases our sensitivity to stress. So one of the advice we can give to switch from simple to complex carbohydrates and have the diet which is more rich in the fiber. Fiber is very important, and less sugar, more fiber, more plant-based food, right? So this is something we can modify. And Serotonin, the happy hormone, is made from tryptophan. So a lot of plants, the food that comes from the plant sources, they have the tryptophan that might add to our happiness. Caffeine and alcohol, they do not help, right? It can increase the stress and decrease our coping mechanism. Exercise, special, very important. So if we look at the, for example, exercise, right, at the guidelines, there are very specific recommendations how much exercise we need to do in order to decrease our the cardiovascular risk. But something I want to mention, that any exercise, right, even walking, and it doesn't have to be 10,000 steps, even if there are 2,000, 3,000, 4,000, any exercise and any activity is better than what is advised by medical societies. Aerobic exercise important. So to have that sweat, little bit, right? Sweat, it decreases the level of the stress. Diet, I mentioned a little bit on the previous slide, but also calcium-rich foods. Why? Why calcium? Because estrogen affects the calcium metabolism. And calcium is helpful in decreasing the level of the stress and also helps with some of the symptoms of PMS. So yogurt, leafy green vegetables, and decrease the intake of fat, salt, and sugar. We mentioned about caffeine and alcohol. Also, how we eat. Do we eat big, large meals, or we have small snacks and several meals rather than large meals? Important. When I mentioned fiber, something I want to say about the fiber. So fiber also comes from plants, right? So it's not easily digested, not fully digested, but it maintains the healthy microbiome of bacteria. And why those bacteria are important? Because what they do, they actually take the waste of the hormones. So hormones that are produced in excess or metabolized that we don't need anymore, and they clear that excess, and something that we need, they reprocess and send back to our bloodstream. So they maintain that hormonal homeostasis. So that healthy bacteria and healthy gut is very important, and it is affected by our diet and our lifestyle. Acupuncture. So research, it's hard to do randomized controlled trials, but acupuncture has been around for many years. If it's not proved that it helps, at least it does not hurt. So certainly worth trying. And it might modulate some endogenous opioids, prostaglandins, right? This is that they have calming effect and decrease the inflammation. So certainly worth trying. So there are some studies that they looked at the acupuncture as an addition to hormonal therapy and showed some benefit. Nutritional supplements. Why are they called supplements? Because they're supplements to what we do every day. They're supplements to our diet, supplements to our lifestyle. And if we take medications, right, prescribed medications, there's also supplement to prescribed medications. So something I just want to mention about supplements is they are the FDA oversees them, right? But there's no strict control of the dosage of the supplements. So let's say if you go to the pharmacy and sometimes you don't know what to choose, there are different dosages. So I just want to ask you to choose something from the brands that are more long time on the market, they're tested on the market, rather than the supplements that we don't know. Because certain supplements might have 0 to very high doses of that particular supplement, And even though most of them, they don't cause harm, but sometimes if the dosage is high or we don't know how much we take too much, sometimes they can cause the harm. One of the examples is, for example, vitamin B6, right? Pyridoxine, B6. So some studies showed the improved mood, improved PMS, PMDD symptoms with vitamin B6. But if you take very high dose of B6, that you might have it might affect the nerves, right? The new create damage in our neural system. So we have to be careful. I mentioned about calcium. So calcium supplementation, it's not only for PMS, PMDD, but also important for our bone health. We lose our bone starting in late 20s. It's not that menopause when it happens, the loss of the bone, but it starts to happen early. So calcium supplementation is important. And calcium does affect the metabolism of the serotonin and of the estrogen. So that's why supplementing is good. Vitamin D, certainly we all know that, sometimes in winter, right, our mood, we're more stressed, the mood is down, we're more depressed. So we all know that vitamin D is important and sunlight is important. So if you're at work and you have a break, please, if there is a sun, try to go out and try to catch sun as much as possible also. Supplements like vitamin E has been shown to reduce symptoms of PMS. Primrose oil might reduce the bloating. Magnesium, right? We know that sometimes supplementation of magnesium, and it's the magnesium citrate and magnesium glycinate. The combination works better. So certainly in let's say the pharmacy, you can ask for magnesium, and magnesium can help with the sleep, and it has some calming effect and might help with bloating and the water retention. Research is coming up about the saffron, right? This is the herb that's added. I know that many ethnicities have saffron as part of the dietary or culinary supplement. So there is more research coming up that saffron might be actually as effective as some of the medications, such as SSRIs. So this is something to keep an eye on upcoming research. Chasteberry has been also around for quite some time, and it stimulates what we call the dopamine receptors. These are receptors in the brain that they do affect the hormone levels. Again, how much chasteberry in certain formulations we do not know, but certainly when you take if you take chasteberry, try to take in the dosages that are advised by the pharmacy and don't go over, right? So besides supplements, besides diet, exercise, important, and sometimes they help. Sometimes they help. We can manage ourselves, but it comes sometimes to the point that we cannot, right? So that's when we talk about the syndrome rather than just premenstrual symptoms. We talk about syndrome. We talk about the PMDD. And PMDD can be very, very serious. Please do not ignore it, because when I mentioned the suicidality, you imagine only 2 to 5% of women, they meet the criteria of PMDD, but out of those 2 to 5%, more than 80% think about suicidality, and close to 30% out of the women have tried to commit the suicide. So this is extremely alarming. So it needs to be taken very, very seriously. So that's when the self-managing, if it's not helping and you're bothered and it affects your function, this is the time to add and think about adding the pharmacological treatments, right? And the goal is to decrease the severity and also think about family planning, because there are different types of different ways that we can give the hormones, the replacement of the hormones. So most of the time when we talk about PMS, we talk about reproductively active women. So someone who is interested in contraception, right? So that's where the dual role of contraceptive pills come in. So they serve the contraceptive purposes, and they also serve the purpose of easing the symptoms. But if we take birth control, as I mentioned, the dosage and formulations are very different. And there is no research saying that this particular birth control is better than the other one. And one thing I can say that if you take birth control, try to take it continuously. What does it mean continuous? So when the pack comes and it has active pills and it has placebo pills, right, just sugar pills, we can actually throw away the sugar pills and start the new pack right away. So take it continuously. There are certain birth control on the market. They're called seasonal, seasonic. They're already designed in the continuous fashion. So why continuous? Because they are avoiding that fluctuation, that drop of the hormones during that placebo period, and you have a continuous and steady level of hormone that helps with the symptoms. So we have to always consider patient preferences and previous treatments that were tried and they failed, or they're really working very well. So when we talk also about the hormone replacement therapy, right? Birth control is hormone replacement. Just think about it, that during reproductive years, our hormone levels are quite high. So you need something in that level, in a high level, to be able to suppress the fluctuation, suppress the ovulation. But sometimes the hormone therapy that's prescribed during menopause, right? Your hormone therapy prescribed during menopause has lower levels, not as high. It's not necessary to have high levels. But even in premenopausal levels, those low levels of hormones sometimes can help if contraception is not desired. You don't want the contraception, but you want to help with the mood and the symptoms, that we can go with lower level of hormones that are safer. Let's say in terms of the blood clots, they're safer. Sometimes you can give as a patch, and patch bypasses the liver, so there's no increased risk of the blood clots. And something to remember, that birth control has
The flu vaccine is more important than ever. This year, you can get a
there
flu
is,
vaccine at the
if
same
someone
time as
can mute, please, thank you. So birth control have both estrogen and progesterone. There is no birth control has natural progesterone. They're all synthetic. So synthetic progesterones can affect the mood more than natural. But the hormone replacement, the menopausal hormone replacement, some of the formulations designed to have natural progesterone, so both natural estrogen and progesterone. So birth control can have natural estrogen but synthetic progesterone. The hormone replacement can have both natural estrogen and progesterone, so have better safety profile, and sometimes patients might prefer that, right? The new research comes out about what we call the NSAIDs, right? We all know ibuprofen, Advil, but also mefenamic acid, that can happen especially with the physical symptoms of the pain, but also mental symptoms of mood swings and fatigue and the behavioral symptoms. As an OBGYN, I prescribe probably more oral contraceptive pills than the SSRIs or the treatments that psychiatrists are more familiar with. But as an OBGYN, I also prescribe certain types, right? The limited types of SSRIs. They're called the serotonin reuptake inhibitor. So the term itself, you see, we want the serotonin, right? We want high levels of happy hormone, but sometimes our body, it uptakes, so it doesn't release into bloodstream as much serotonin as we would like. That causes depression. So what these medications do, they actually inhibit that uptake. So they make sure that we sustain the serotonin levels in our bloodstream. There are various formulations of SSRIs, SNRIs with different dosages. As OBGYNs, we usually start with the low doses, and if the higher dosage is required or it's not helping, we certainly refer to our psychiatric colleagues. But something to be aware that OBGYN can give SSRIs as well. There are different ways of prescribing. So what is interesting, that let's say if there is a psychiatric disorder, depression, anxiety, and you start SSRIs, it takes some time to see the effect. Sometimes takes 6 to 8 weeks to see effect, and you need higher doses. It looks like mechanisms in PMS, PMDD are different. I mentioned those GABA receptors, right? So it works through those GABA receptors. Once you take it, you feel the effect right away. So if you feel effect right away, they can be prescribed only when symptoms appear, or maybe let's say in the second half of the menstrual cycle, or at the beginning of the menstrual cycle, and only for the limited amount of the time. So if we're talking about the withdrawal that might happen. So you need to taper down the psychiatric medications. There are higher doses. In these dosages, and for PMS, PMDD, you might not need to taper, and you might not experience those withdrawal symptoms, which is different.
To call themselves American for reasons that time.
Wow. So again, you can give continuously, you can give during luteal phase only, you can give as required, but the mechanism is different. So what happens that once you stop, if they help, but if you stop SSRIs, unfortunately, those symptoms might relapse, right? This is a chronic condition. This is not something that you can treat. You can relieve the symptoms, but the underlying mechanism is hard to treat, right? That's why sometimes people ask me, is it a disability? So in a way, it is a disability because it's a chronic condition, but you can help, you can make it milder, right? Or you can sometimes even make it go away with interventions and pharmacological interventions. And birth control, I mentioned the birth control, different birth control pills. One of the OCPs that you probably hear, right? You probably hear Yaz, you've heard Yaz or Yasmin. It has certain type of progesterone, which some research showed that it might be more effective than other birth control pill. But the interesting part that study that said that this Yaz is more effective than other pills also had very strong what we call placebo effect. So women were giving the Yaz versus placebo, just a random sugar pill. And women that were taking placebo showed as much improvement of symptoms as Yaz. So even though research showed that this is an effective medication, we don't know if it's more effective than other OCPs or more effective than placebo. But certainly we do prescribe Yaz as a first-line birth control pill. Has I mentioned the progesterone that's called the drospirenone that decreases the bloating and helps with the mental symptoms also. Let's say we tried self-care, education, lifestyle modification, diet, exercise, and even the pharmacological intervention, right, such as birth control or SSRIs, SNRIs, and so forth. And symptoms still, they either continue to be severe or they're milder, but still very bothersome, right? So what happens? The idea is that we need to reach the level of the steady hormones. So level of steady hormones that sometimes we see in postmenopause, level of steady hormones that we see in the adolescent girls before they start to menstruate. So steady, quiet state. So how do we reach that steady, quiet state? Sometimes we have to give the medications that put us into so-called pseudomenopausal state, right? So we have to shut down our what's called the hypothalamus pituitary ovarian uterine axis, that axis that sends hormones up and down. We need to shut it down. And there are certain medications, so they're called the gonadotropin releasing hormone agonists. What they do, they shut down the hormones on the brain level. But it's a pseudomenopause, right? So what we do, we substitute the anxiety and the depression associated with PMS, PMDD with sometimes anxiety, depression that's associated with the menopause, right? With menopausal state. So in certain situations, it helps. In certain situations, it does not help. Sometimes it's what we do that once we're in that pseudomenopause, our bone is affected, our heart might be affected. So these medications, they might be helpful, but we cannot give them forever. We can give only 6 to 9 months. And if we give for a prolonged time, 6 to 9 months, we need to give that add back of the hormones to be able to maintain the bone health, to maintain the heart health. But once to start giving that add back estrogen, add back progesterone, those mental symptoms and physical symptoms might come back too. So yes, we use these medications if everything else does not work, and it does sometimes decreases PMS, PMDD, but Also, we need to be careful with that, that we need to give ADVEC therapy, first of all, but also we need to watch for exacerbation of the symptoms once we give that ADVEC therapy, right? So this slide just talks about what I mentioned about the ADVEC therapy in the previous slide. Uh, Sometimes there are specific symptoms. So there's only bloating or there's only breast pain. So there are certain medications that can be geared just for those specific symptoms. For example, bromocriptine for breast pain or spironolactone for bloating. So that's why it's very important to be specific. And for healthcare provider to know. So this is not just PMS, PMDD, it's the syndrome, but it might be just those particular symptoms that are bothersome, and we can specifically address those symptoms, right? So surgical management. It's hard to imagine that the mood or bloating or breast tenderness, we can occasionally we need to address with the surgical management, right? It's hard to link one with another. But when we're talking about steady level of hormones, you can either suppress them with medications, or sometimes we have to go as far as removing ovaries, not having those hormones in the body. Interesting is that if we remove just the uterus but not ovaries, occasionally that improves symptoms also. It's hard to understand because hormones are still there, but it might be that ovarian function changes with removing of the uterus and the blood supply. But removing of the uterus and ovaries both certainly puts in the menopausal state and not having those hormones around. But these are again drastic measures for PMS, PMDD. Are there a few patients that we need to do it? And yes, they are, right? So what are the key points that I mentioned throughout the presentation? That PMDD is much more severe than PMS. These symptoms are cyclical. So if they're not cyclical, if they're not continuous, we need to think about different diagnosis, and we need to think about psychiatric disorders rather than PMS and PMDD, different psychiatric disorders. Tracking of symptoms is very important, and tracking them prospectively, not retrospectively. Self-care is important, such as diet, exercise, reducing alcohol, caffeine, sugar, right? Intake more complex carbohydrates and nutrients. Consider vitamins, consider calcium, magnesium, vitamin D. Prioritize consistent and high quality sleep to improve the energy, to improve the coping mechanism. Utilize the mindfulness, meditation, cognitive behavioral therapy, right? Something I did not mention before. It was on the slides, but I did not mention, also very important. The group therapies. So having that support and sharing and mindfulness is also therapeutic. And of course, when self-care is not working, please consult the providers for potential treatments. There are a lot of treatments that are out there, and maybe one does not work, but another one might work. So it takes time, and we can adjust and we can change. So don't get disheartened and frustrating, and after one visit you're not helped. Sometimes it takes time to develop those relationships with your providers and understand. Takes time for you also to understand the body and what's going on. So, and build a supportive network, very important. Explain not only to ourselves, but to our partners, to other families, and to the support and at work, that what we're going through is physiologic, right? It is linked to what's happening with the hormones, what's happening with our body, and it's not our fault. So build the supportive network that they're aware what's happening. So at the moment when you're irritable, when you're angry, when you maybe want to start the fight, there is someone there that supports you, someone there with you, and they understand you, and they will be able to help you to manage your life, right? So certainly there are many resources on the especially if you look for resources that there's evidence-based guidelines. Please look into American College of OBGYN, American Psychiatric Association, Office of Women's Health, International Association of Premenstrual Disorders. There are a lot of patient information. There are a lot of guidelines and important information on those websites. If you're interested, and just to have the slide how we diagnose, right? I mentioned there is a strict diagnosis for PMDD, so the slide is attached to the presentation, and there are a lot of books that women write, the author write about PMS, PMDD. You're not alone. So if you have time, reading is relaxing, is part of the relaxation, but also is part of the knowledge and part of the empowering. There is something that's called the blue sky phenomenon, right? So when the menstruation starts, sometimes symptoms go away, and patients describe it as a blue sky. So the clouds are over and there's a blue sky. So this is Mount Fuji, and apparently it has the bluest sky in the world. So if nothing, maybe traveling and visiting, right? Visiting different sites and seeing the blue sky, not only for yourself, but also outside, and the sunlight certainly helps. So with that, I will conclude my talk. If you have any additional questions, again, please do not hesitate to reach out to me, and I appreciate your time, your attention.
Thank you. Thank you so much. So can you hear me now?
Yes.
Okay, so apologize for the earlier tech issues, everyone, and thank you so much. So we are so fortunate to have Dr. T and such a wonderful presentation. There were some questions, but I think that many of them were already addressed. So if you feel the question was not answered, please email me, and then I can try to compile those questions and responses and add in the wrap-up email. And thank you, everyone. And I'll be sending the slides and the recording so you can watch it again. And in the interest of time, I'm going to skip going through the upcoming events. I'll include it in the wrap-up email. Thank you, everyone. And thank you so much, Dr. T.
Thank you so much. Thank you for having me.